So this is the patient where we got her. We took the cone beam afterwards. And now I will show you again here a video from a patient. So I have to walk you through, otherwise we lose too much time. So here you see the incision. So a little imagination still left over here. We go into the palate. This is also master class and so on. And here we use the papilla base incision. We do that sometimes when the papillas are really excellent shape, then there's no need to loosen it. This has been often used in our clinic, also in endodontic surgery for apicoectomies by Thomas von Arx, and so on. And now you see we mobilize the flap. I don't have to show this in detail. I want to show you what we have here. This is the important one. So this spontaneous thickening giving you such a nice flap. You have to spend some time here to really do that very carefully. So I changed the instrument to this surgical curette. That's what you get. So of course that depends how much vertical bone resorption took place. If this is only 2 millimeters, then you will not get this nice amount of soft tissue. But when you have there, I don't know, several millimeters of bone resorption, then you get exactly this. This is very thick. The paper we published, the mean thickness was 5 millimeters of these soft tissues. Okay. Here, actually, what you see on the right side, this is Alberto Monche during his time as an ITI scholar here. Did many surgeries with him. So we have had very good experience with the Spaniards. Spanish people, very smart. So here you see then the harvesting of the bone. Sharp is important, a sharp bone scraper. And you see how well that goes. So this goes into the blood bath, and then that goes to the sideline, and they work for you. And it would be interesting. I don't know if you are interested. When I was at Harvard in 2016, they have very good cell biologists there. And one of the ladies, she said that osteocytes, I'm sure osteocytes are regulating this mechanism. So I don't know how to do that because I'm a surgeon. But that could be a very interesting topic to really study that. If the osteocytes are actually the driving force for what we have found. Okay, so then when this is at the sideline, we start to prepare the implant bed. So you see here a crater-like defect. This is a V-shaped defect, not surprising. And we do that step by step. We check first, the first spiral drill gives us an indication of the axis. Axis is most important. So we put that in, the depth gauge, so you can control the depth, and you see exactly where the screw retention will be located. If I see that's not perfectly located, then I move it a little bit more to the palate. Important is to keep the palatal wall fully intact, and it should be more than 1 millimeter in thickness. Very important. Often the palatal wall is also getting wider, so then you can calculate. Where the SLA surface starts, there you need the thickness to be stable. Okay, when everything is fine, we just expand. You have seen that now multiple times. We go and take a round burr number 3, and then we go for the next spiral drill. If this is a TLC, then of course the drills are slightly tapered. This is the velo drills, as they are called. I'm very pleased with them, and so on. And here you see now this is complete. Second spiral drill, third one. And now very important, you see, to show that here. See, we clean out the whole implant bed, and you see here a lot of thin edges. You see, because from the preparation. So I started to take this off about 2004, because I figured out, I learned that this bone is not going to survive. So following this opening with the large spiral drill, as a large profile drill, I asked for a diamond. That was too large, so we get a smaller one. And now I'm just, what I have shown you now in all these cases, I just freshen these bony margins, you could call it, or I don't know what, and we just take the thin edges off. Huh? So, and the other one, what we are doing, we are opening up the cortical bone. So you see the bleeding immediately. And then, of course, as next, we put the implant in. Huh? So this is a parallel-walled bone-level implant. The TLC implant we started in December last year, and I tell you, I'm going to completely switch over. I'm very pleased with the surgical technique. Very easy to do. And interesting, when you put them into a healed site, then ISQ is 85, sometimes 90. We have never seen before. So the thread is slightly more aggressive and gives you more primary stability. So that's for sure not a disadvantage. We have a 1.8 millimeter machine neck for the aesthetic sites. You have to very carefully position it. And what will come, this is not a typical tissue level implant. The prosthetics you can have with this implant is, of course, tissue level approach, that the crown goes to the implant shoulder, but this will also be a certain diameters available, in particular those who are straight up, those we used. Also with the typical bone level prosthetics, that means an abutment, and you have a platform switching device. That means that implant is in a double sense a hybrid. It's a hybrid with two surfaces, and it's a hybrid with two prosthetic approaches. That makes it extremely powerful, this implant. So here you see the implant on the parallel side is below the crest, and then of course the next one is that you see this is not at the same position, obviously. So we have to put a healing cap in. Everything is fine. So here's the healing cap. And then we start to apply the autogenous chips. Here you see then how this is processed. This is the autogenous bone chips. At the sideline, we take the blood and now activate the second bone filler, DBBM. And then we have also an active bone filler there, and that is the beauty. That means we have autogenous bone, continue to release growth factors, and the second filler is now activated. That means the entire area of augmentation underneath the membrane, including the membrane, is active with growth factors. And that, I'm sure, is the key why we have seen in the last 5-6 years even better results when we took cone beams to see how much the tissue formed the bone, also the body of the patient. So, okay, so now you see, I think that is, here you see the release of the flap. Very carefully, don't perforate your flap. Be very careful. And now we see the application of autogenous chips. So I have to move it on. So here you see these are the patient's own bone chips. Did you see how much we had in our last patient? It was a huge amount. And it took me 2 minutes to harvest that bone. It was very easy, just 2 centimeters away from this bony surface. And this is now the activated second DBBM filler that helps me to over contour. Now, autogenous bone alone would never do that because you would not be able to maintain the volume. It would be resorbed, as we know from our own experience and, of course, from all the others. Actually, the same is when you do just autogenous bone for sinus floor elevation. This was done in the 1990s by lots of maxillofacial surgeons. They said, we don't want to use bioos. And then they published 5 years later that they lost 40% of the created bone height by bone remodeling. So this is the same mechanism why in the sinus floor elevation the mixed composite graft is the winner today. So the membrane is then applied, as you have seen now. So we soak it in blood with BCM blood. And then when this is done, of course, very important is to tuck it underneath the palatal flap, so that stabilizes. The membrane becomes very adhesive when it's soaked in blood. And then comes the second strip across, and that's it. Again, gravity is in our favor. The filler would move crestally. If the gravity would have an impact, that's different in the posterior mandible. And then, of course, at the end, you see the suturing. I think we can go ahead now. Okay, here you see the final suturing, and then the suturing is done. So you see the patient at 8 weeks. When we did the reopening, then Professor Belser took over and did a provisional made of acrylic. And then a couple of months later on, then he produced together with Pascal Müller, a very, very talented dental technician from Zurich, then a new crown. They also did, I think, a crown at the adjacent tooth because the patient didn't like that anymore. And then we have 2 new crowns, 2 supported and implant supported. I mean, a fabulous outcome.